Hello? Hello, am I audible?
Yes, we can hear
Okay,
you.
okay, that's great. So let's start our today's session. Let me share my screen first. Can you guys just see my screen? Hello?
Yes.
Okay, that's perfect. So, day after tomorrow, we were discussing about rotator cuff muscles, right? And we discussed a mnemonic called SITS. S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapular. Right? We discussed the supraspinatus. We know that we have a spine within the scapula. Above it, we are going to be having supraspinatus muscle. We discussed the entire details. So today we are going to continue from infraspinatus, right? So as the name indicates, infraspinatus. Infra mean below, below the spine. So you guys can see which muscle is present below the spine. This is going to be infraspinatus. Is it clear? Because it's present below the spine. Am I right? Hello? Hello?
Yes,
Yes.
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 Okay, okay, perfect, right? So this is basically your infraspinatus. So let's discuss what is the function of infraspinatus, right? So infraspinatus basically helps in external rotation and abduction of the shoulder. So you can see it here, right? If I'm just pulling this muscle from its origin side, it's going to be attached on the, on the arm. So what is going to be the function of it? It's going to cause abduction. It's going to pull the arm. Okay, it's going to cause abduction or adduction. Going to cause abduction of the shoulder, right? Not adduction. Okay. So as we pull this muscle, so it means that the insertion side of this muscle is going to be somewhere here, right? Am I right? Hello.
Yes. Yes.
Yes,
Okay.
sir.
It's going to be the muscle. The insertion side must be somewhere here, right? So if I'm just pulling this muscle, so the hand is going to get abducted. The arm is going to get abducted, right? And it's also going to be helping in external rotation of your arm. That's really important to know the function of infraspinatus, right? So infraspinatus basically is going to cause external rotation. You guys know what is external rotation and what is internal rotation. What's going to be the nerve supply of infraspinatus? That's going to be suprascapular nerve. If you remember, suprascapular nerve was also supplying to which of the muscle which we discussed yesterday?
The
Supraspinatus.
supraspinatus. Yes.
Supraspinatus. It means that the supraspinatus and the infraspinatus, both of them have common nerve supply, right? So how does the infraspinatus get injured or get damaged? It's going to be damaged in a overhead thrower. So you guys can see whoever is bowling or anything, right? So it's going to be a whole overhead thrower in which this muscle is going to be injured. But really important thing about supraspinatus we discussed that commonly we are going to be having impingement of the nerve tendon between the acromion process and head of humerus. Did you guys remember that? And the test in order to look for whether we have injury of supraspinatus, what was the test we discussed?
Empty can test.
Empty can or full can test, right? So that was, but in case of infraspinatus, we do not have any test in order to look for whether we have, injury or damage to the infraspinatus. So we do not have certain like tests which can access, assess only the function of infraspinatus. Like for the supraspinatus, there was empty and full can test. If we have pain there, we discussed that we can just know whether your supraspinatus is impinged or it's injured, right? The next muscle which we are going to discuss is teres minor, right? So you can see the teres minor here, right? So it's going to be your teres minor muscle, right? What's going to be the function of teres minor? As you guys can see here, you know, okay, which one is this? Is your teres minor, okay? Not this. So teres minor is going to cause adduction of the shoulder. You guys can see that teres minor, if I just pull this teres minor from its origin side, it's going to cause abduction of your hand. Am I right? Adduction of your hand. Am I right? It's going to aid the hand towards your body. Am I right?
Yes.
And it's also going to cause external rotation, right? So external rotation for teres minor. It's really important. You are going to be having a U World MCQ based on this. What is the function of teres minor, right? So teres minor basically causes adduction and external rotation, adduction and internal rotation, right? Sorry, external rotation, right? Okay, what's the nervous supply? The nervous supply is axillary nerve. Axillary nerve also supplies the deltoid, right? we discussed the function of deltoid. Did you guys remember yesterday? 15% of the initial abduction is caused by which muscle?
Supraspinatus.
Supraspinatus.
Supraspinatus. And above 15 till 90 degree, which muscle is going to cause it?
Deltoid.
Deltoid.
That is going to be deltoid. What's the nervous supply of deltoid? Auxiliary nerve as well, right? So auxiliary nerve is going to both supply your teres minor and your deltoid. That's important to know, okay? Okay. So let's discuss our next slide, our last muscle, which is subscapularis. So as the name indicates, subscapularis, it's going to be present, in this region, like it's going to be lining the inner portion of your scapula, right? It's going to be your subscapularis muscle, right? So what is the function of subscapularis muscle? Is going to cause internal rotation. You can see if I just, pull this muscle from its origin side, it's going to cause internal rotation, right? Internal rotation of shoulder and arm. That's the function of subscapularis muscle. And what's the nervous supply? The nervous supply is upper and lower subscapular nerve. So as we have subscapularis supplied by subscapular nerves. So these were all of the rotator cuff muscles which we discussed, right? So let me just give you a quick overview of these muscles, then we are going to move forward, right? Okay. Okay, so we discussed rotator cuff muscles. What are your rotator cuff muscles? Whenever you are abducting your arm, they are going to hold your head of your humerus into the glenoid fossa. They are going to cause, they're going to lead to stability of your shoulder. In other words, I can say that, right? What are going to be the muscles? The mnemonic for that is SITS. S for supraspinatus, infraspinatus, subscapularis, and teres minor, right? Okay. We discussed supraspinatus is going to be present above the spine. If we just pull this muscle from its origin side, it's going to lead to abduction, the 15% abduction. We discussed that it's the most common rotator cuff injury is going to be seen in this muscle. Why? Due to impingement between your acromion process and head of humerus. We know that. Okay, so you guys can see here the tendon can get compressed between the acromion process. Okay, how do we assess whether we have any problem with supraspinatus muscle? That was an empty can or a full can test. So individual have to do make his hand at 90 degree and he's going to push the hand upward towards the sky. We are going to pull it downward. So if he's experiencing pain, it means we have damage of your supraspinatus. Then we discuss infraspinatus below the spine. What's going to be the function of this muscle? It's going to lead to abduction and external rotation, right? Abduction and external rotation. And the nervous supply is same as that of supraspinatus muscle. Then we discussed teres minor. It's going to lead to adduction and external rotation, right? So the only difference between teres minor and infraspinatus is that both of them cause external rotation, but infraspinatus causes abduction while teres minor causes adduction. The nervous supply of teres minor is same as that of your deltoid, which is going to lead to abduction above 15 degree till 90 degree, right? Okay, then we have subscapularis. The nervous supply is going to be subscapular nerve, and the function of it is going to be internal rotation of shoulder. That's all, okay? Let's discuss our brachial plexus. So what are brachial plexus? As the name indicates, brachial for the arm, plexus for the different groups of nerve. It means that they are basically, network of nerves which are going to supply your upper limb or upper arm, right? And they're going to be having both motor and sensory supply of your upper limb is going to be given that by these brachial plexus, right? So let's discuss these brachial plexus in a little bit detail, right? So they basically arises from a C5 to T1, right? Okay, so the first C5 and C6 will basically join together to form an upper trunk, right? So we have roots, we have trunks, we have division, we have cords, right? Okay, so the C5 and C6 will combine. It's just going to form the upper trunk. Okay, upper trunk. Your C7 is going to, move just like that, giving you your middle trunk. And your inferior trunk is going to be, again, due to combination of C8 and T1, collectively giving your lower trunk. So this upper trunk and lower trunk is really important. We are going to be discussing that in detail, right? Okay, and once the trunks are, further go, they are going to be divided into divisions, right? So the from the C7 and from the upper both of the trunk, we are going to be having this division, right? Then we have the C7 is going to move directly and it's going to join with the C8 to give us posterior cord. It's going to give us a lateral cord and it's going to give us the medial cord, right? So we have different nerves which arises from the brachial plexus. First of all, you should know this long thoracic nerve. We are going to discuss in detail which muscle do it supply, the long thoracic nerve. Okay, so we have a mnemonic called as MARMU. It's really important, right? So M for musculocutaneous, which we'll be discussing, A for axillary, R for your radial nerve, right? This is your radial nerve. M for your medial cutaneous nerve of forearm, and okay, M and U for ulnar nerve, right? So you should know the exact distribution of these nerves by knowing this mnemonic. In the U world, they are going to give you a picture and they are going to mark an arrow to this and they are going to ask you, what is this nerve, right? So if you know the mnemonic, you can easily know, which nerve are they talking about, right? And let me just mention one thing. In your neuroanatomy, you're going to see all of the MCQs from this MSK, right? So neuroanatomy is your MSK MCQs, the neuroanatomy, the anatomy portion of that, okay? So you will be seeing it in in the U world of your neuro section, right? Shoulder movement.
Can you repeat the mnemonic, please?
Okay, MARMU, MARMU, right? That's MARMU, MARMU, okay? It's going to be the mnemonic from which you can know which nerves are arising from, which portions of your brachial plexus.
Oh my God.
So let's discuss the shoulder movement, right? We discussed deltoid. Deltoid is this muscle, you can see, right? This is your deltoid muscle, right? Okay, we know the nervous supply is going to be supplied by axillary nerve, right? What's the function? We discussed the function. Supraspinatus initially is going to cause abduction till 15 degree, but from 15 to 90 or 100 degree, your deltoid is going to cause that abduction. Is it clear? And above the 100 degree, your trapezius and serratus interior, which I'm going to mention in the next diagram, is going to lead to abduction above 100 or 90 degree. Is it clear? Your trapezius and your serratus interior. Okay. Okay. So let's discuss shoulder dislocation. It's really important. Okay. So whenever we have anterior dislocation of humeral head, really important, one of your UWorld MCQ. What do you mean by anterior dislocation? For example, if this is your shoulder joint and your humerus move anterior, due to any kind of dislocation, so which nerve is going to be injured? That's really important, one of your UWorld MCQ. Anterior dislocation of humeral head is going to lead to injury of which nerve? Yes?
Axillary.
Axillary.
Axillary nerve. Perfect, right? So anterior, just note it down. It's one of your UWorld MCQ. Anterior dislocation of shoulder is going to give injury to axillary nerve, right? It's going to be present in the axilla and the head of your humerus. So once we have anterior dislocation, that's going to lead to damage of your axillary nerve, right? So you can see that anterior dislocation of humerus. So vulnerable arm is going to be abducted, externally rotated, and extended. Yes. What do you think? Hello? Hello? Hello?
Doctor, could you please repeat?
Hello? Can you hear me properly?
Yes, I can hear you.
Okay. So whenever we have like a trauma, how can we get trauma? And the trauma can be like seen in blocking of a basketball shot. If someone is just blocking the shot, we can have anterior dislocation. Tackle while throwing a football, it can also lead to anterior dislocation of shoulder, and the vulnerable arm is going to be abducted, externally rotated, and extended, right? We are going to discuss it in a while. Okay. So the common injury of the nerve is going to be axillary nerve, right? As we know that axillary nerve run below the humeral head, and it would wrap around the neck. It would wrap around the neck of your humerus. So whenever we have, dislocation of this nerve or anterior displacement of the humerus head, we're going to be having damage to axillary nerve. That's really important. If you guys cannot memorize it, no problem. But this should be really high yield to keep in mind. Anterior dislocation leads to axillary nerve injury, right? Okay, so if the axillary nerve is gone, what would happen as a result of that? Can our arm do abduction if the deltoid is gone?
No.
No,
Yes.
no. No.
Okay, so the abduction above 15 degree to 90 degree cannot be occur, right? So we can have weak abduction due to that supraspinatus, but we won't be having strong abduction, which is basically going to be done by your deltoid muscle. Besides that, we know that the sensory supply on the surface of deltoid, like here, is also going to be given by axillary nerve. So axillary nerve is going to give motor supply to the deltoid muscle and sensory supply just above the deltoid muscle, right? The skin above the deltoid muscle. Okay, so humerus fracture. Let's discuss humerus fracture. That's very important, right? Okay, just give me a second. So humerus fracture is basically going to be seen in elderly, as they are mentioning here. So we can have damage of the humerus, at two locations. That's really important, right? So we can have proximal humerus fracture. And what can be the causes of that fracture? That's really important. For example, if we have disruption of the blood supply here to the humerus head, right? So we know that if this is your humerus, we have some blood supply to the head given by circumflex artery, if you guys remember, right? Circumflex arteries, right? So if we have disruption of those circumflex artery, so now you do not have the blood, you can't provide the nutrients to the head of your humerus, which can lead to weakening of the bone, necrosis of the bone, or fracture of the bone, right? Is it clear? Okay, and these circumflex branches basically comes out from your axillary artery. Is it clear? Hello?
Yes, sir.
Yes, it is.
So if we have direct fracture to the head of your humerus, it can also lead to disruption of the blood supply as well, right? Which can lead to necrosis, right? So the proximal humerus nerve, okay, you can see you have brachial plexus, axillary nerve, loss of abduction deltoid as well. So near the periphery of this humerus head, as we discussed, we also have axillary nerve, as we discussed. It's going to be present here near the head of your humerus. So if we have any kind of fracture there, if you have any kind of trauma there, so it can also disrupt your axillary nerve as well, as we discussed in anterior dislocation, because both of the head of your humerus and the axillary nerve, they lie really in close proximity to one another, right? So any kind of trauma to the head of your humerus is also going to impact the nervous supply to your deltoid, that's axillary nerve, and again we'll be having weak abduction as we discussed. Is it clear? Okay, so let's discuss elbow. Elbow is really important joint. Okay, so we know that elbow is basically made up of three bones. We know that. Okay, let me just write it down here. Okay, what are the bones which make your elbow joint? We have your humerus, the distal part of your humerus. We have your ulna, which is present at the medial aspect if you are standing in an anatomical position, right? All of you guys know what is anatomical position. If you are just facing your palms anteriorly and standing, that's your anatomical position. So in anatomical position, ulna is going to be inward, ulna inward, that is towards the medial aspect, and the radius is going to be at the lateral aspect if you are standing in anatomical position, right? So here you should just keep in mind this annular ligament. It's really important. I'll be discussing one of the pathology which is basically going to be concerned about this annular ligament as well. So you can see that from the ulna we have a ligament which is known as annular ligament, right? And the head of radius is basically it have like a hold the head of your radius as well, right? So we'll be discussing a pathology. We can have sometime the head of the radius can slip this annular ligament, and we are going to be having a condition which we'll be discussing in a bit. Okay, so we have three bones here. We have humerus in the upper arm, we know that. We have radius and ulna. Ulna is present to the medial aspect whenever we are standing in anatomical position, and radius to the lateral aspect. Okay, so prone to overuse injury. We can, okay, so in two conditions we'll be discussing, we can have injury to these to here in the elbow. But before discussing that, let me tell you a really important concept, right? It's going to help you a lot. For example, if this is your humerus, right, and this is the distal part of the humerus, so we know that the humerus itself has these big bulges, and we discussed these big bulges are called as condyles. Remember? Hello?
Yes.
And above
Yes.
these structures, the small bulges are called as epicondyles. Okay, they are epicondyles. Remember one thing. Okay, the medial side of epicondyles are going to give rise to all of the flexor muscles of your forearm and your hand. Keep that in mind, right? So the medial epicondyle is going to be the origin for all of your flexor muscles. Okay, for all of your flexor muscle, flexors of your wrist, flexors of your, we'll be discussing there flexor digitorum profundus, extrinsic muscle of your hand. That's going to be arising from the medial epicondyle. So really important, medial epicondyle is going to give rise to flexor muscles. while the lateral epicondyle is going to give rise to your extensor muscles. Really important, right? Extensor muscles. What are extensor muscles? It's going to extend your your wrist, and it's also going to lead to extension of your fingers as well, which are basically going to be supplied by the radial nerve, which we'll be discussing in a bit, right? But till now, you should know that medial epicondyle is going to give rise to which muscles? Yes.
Flexors.
Lateral
Flexors.
epicondyle give rise to which muscles?
All the extent.
Extensor.
Extend.
All of the most of the extensor muscles. Okay, so let's discuss epicondylitis. What is epicondylitis? It's basically, any kind of due to overuse of muscles, which we'll be discussing, due to overuse of flexors and extensor. Sometimes you can have epicondylitis. You can have like a kind of condylitis, a kind of inflammatory condition in which you'll be having swelling there, and you cannot use your arm further. That's called as epicondylitis, and mostly it's going to be due to overuse injury, because we know that the medial epicondyle is going to give rise to flexor muscles. So if I'm using a lot of flexor muscles in certain games which we'll be discussing, so we can have all of the the forces or overuse forces is going to be experienced by your origin here, which is your medial epicondyle, right? So it can lead to medial epicondylitis. And in those sports in which we mostly use our extensor muscles, a lot of time repeatedly we are using them, so we can get lateral epicondylitis in that cases, right? So let's discuss it now, right? So lateral epicondyle, we know that bone origin of wrist extensor. Medial epicondyle is going to give rise to your wrist flexure, right? Epicondylitis, chronic tendinosis, right? In which we are overusing these muscles, which will lead to inflammation kind of condition there at the epicondyle, right? So we are going to be having few inflammatory cells, disorganized tissues and vessels as well, and it's going to be a really painful condition, right? So pain on the medial or pain on the lateral elbow is going to be seen. If you are using a lot of extensor muscles, so lateral epicondylitis is going to be seen. If you are using a lot of flexor muscles, so medial epicondylitis is going to be seen, which is due to repetitive movements, right? So epicondylitis, lateral epicondylitis is most commonly seen in tennis, those who are playing tennis, right? So that's why it's called as tennis elbow. So you can just, how do we use tennis? Which group of muscles do we use in tennis mostly? What do you think?
Flexors.
Flexors or extensors?
Extensors. We extend the hand and then
Extensor. Extensor.
Extensors. Like we are just moving the tennis backward again, right? So that's using of extensor muscles, right? So and those who are playing tennis for a long period of time, they are using a lot of extensor muscles. So what do you think? Which epicondylitis are we going to see? Medial or lateral?
lateral.
Lateral.
You have lateral epicondylitis, and then it's going to be really painful situation, as I discussed with you. And you cannot then there is going to be a restricted wrist extension, because if you have inflammation at the lateral epicondyle, which is the origin side for your extensor, obviously you'll be having a lot of problem, a lot of pain once you're tennis again, right? The next one is medial epicondylitis. So those who are just playing golf, what do you think? You are using flexors a lot or extensors a lot?
Flexors.
Flexors a lot. If you're using a lot of flexors, what do you think? What is the origin side of your flexors?
Medial.
Medial.
Medial
If you're repetitively using that, you are going to have medial epicondylitis. Is it clear? Okay. Nursemaid elbow. What is nursemaid elbow? As I already told you that you can see the radial head is basically, you can see the head of the radius is joined in this bone, and here you have an annular ligament, right? Annular ligament, which is present, which is like, keeping the head of radius, tightly in association with your ulna, right? So sometimes if you have a baby and he is falling, right, it's also known as nursemaid elbow. Why? Like, for example, if you have a baby and he's falling and you suddenly just hold him from the hand, right? Suddenly hold, like if you have a small baby and he's just falling. So what you do, you just hold him from the hand. And as you hold it from the hand, so this radius is going to move out from this annular ligament, right? It's going to slip. It's going to be having outward movement from this, annular ligament, which is going to, or partially it's going to be either it can completely move out of your annular ligament, or partially it can just displace and it can just move out of this, your ligament, that's your annular ligament, right? So this condition is basically known as nursemaid elbows, right? Or radial head subluxation. Okay. So you can see axial traction. What is axial traction? Baby is falling. You are holding him from the hand suddenly. Gravity is going to pull him downward and you are just pulling him upward. So obviously the head of the radius is partially or completely gonna move out of that annular ligament. Am I right? And this kind of traction is an axial traction, right? You're just having this kind of traction, axial, right? Is it clear? Okay. So the head of the radius is going to slip out or slip over this annular ligament. Is it clear? Hello?
Yes, sir. Yes, it is clear.
Okay, perfect. Okay. So let's discuss our next condition, that is supracondylar fracture. Without looking into this its text, what do you suggest? What is supracondylar fracture? We discussed what is condyles. Condyles are basically these big bulges, right? These are condyles. So supracondylar fracture means that above the condyle we have a fracture, right? That's it.
Yes, sir. Yes.
Okay. As we have supracondylar fracture, it's really important to know that which nerve is going to be damaged here. Which nerve passes just directly above your supracondyle? Yes.
Median nerve.
Median.
Median.
Perfect.
Brachial artery.
Median nerve is going to be damaged. This is one of your U-word MCQ. So in the U-word MCQ, they're going to give you picture, something like that. You can see it's a fracture here above the condyle, right? And they're going to ask you which nerve is going to be affected, which nerve is going to be injured here. So your answer should be median nerve. We'll be discussing what's the function of median nerve in a while, okay? And your brachial artery is also going to be present there, right? So in supracondylar fracture, two things are going to be injured, one of which is going to be your median nerve and your brachial artery is going to be injured, right? So injury to the bone is, it's the most common neurovascular injury in supracondylar fractures. Radial and ulnar nerve may also be injured, right? Remember one thing, we know that we have ulnar nerve and we have a radial nerve, right? Ulnar nerve is going to move, it's going to supply something in hand, which I'm going to discuss. And radial nerve is the nerve which is going to provide your innervation to your extensor, right? So you can see ulnar to the hand, radial to extensor, right? So if we have fracture of them, it means that ulna is present at the medial, whenever someone is standing at anatomical position, ulna is present medially, right? Towards the radius. Am I right?
Yes, yes.
We call ulnar nerve and ulna because it's going to pass over the ulna, right? That's why we call it as ulnar nerve, right? So can I say whenever we have damage to the medial epicondyle, most probably the ulnar nerve is going to be damaged. Can I say that?
Yes. Also just behind.
Okay. A radial nerve is going to supply the extensor. Extensors come out from your lateral epicondyle. Right? So whenever we have damage to the lateral epicondyle, we can have damage to the radial nerve. That's really important to know. Okay. Okay. So let's discuss the median nerve, ulnar nerve here. So it's going to be really easy for us, once we are just discussing that. Okay. Let me just tell you that what does the ulnar and medial nerve supply, right? So for example, if this is your hand, okay, let me just draw a hand. 1, 2, 3, 4, and this is the thumb. Really sorry for this diagram, okay? Okay. Remember at the thumb side, we have certain muscles which are called as which muscles? Thenar or hypothenar?
Thenar.
Thenar.
Thenar muscles. And here at the little finger, we have, okay, so this is basically your first digit, second digit, third digit, fourth digit, and fifth digit. Thumb is always the first digit, right? So these muscles are going to be called as
Hypothenar.
muscles, right? Remember, what's the nervous? Okay, the median nerve is going to supply the thenar muscles, okay? And that's going to be the motor supply, okay? It's going to supply the sensory of 1, 2, 3, 3.5 sensory. All of these sensory sensations are going to be provided by your median nerve. So it's the sensory sensations, 2, 3.5 fingers, 1, 2, 3, 3.5 fingers. Sensory on the palmar side is going to be supplied by your median nerve. Which muscles do median nerve supply? Median nerve supplies the thenar muscles. What else? It supplies the lateral two lumbricals as well. What are lumbricals? Do you guys know? Hello?
The interosseous muscles.
In
Okay.
between fingers.
Okay, so we have 4 lumbricals. Keep that in mind. 1, 2, 3, and 4. Can I name these two as, okay, whenever we are standing in anatomical position, can I name these as lateral lumbricals and these two as
Yes.
medial lumbricals?
Yes.
What is the function of lumbricals? That's really important. It would form L from your fingers. What do I mean by L? Just make an L at the metacarpophalangeal joint, right? So if this is your hand, this is going to be your metacarpophalangeal joint, right? So if you just flex it and extend the interphalangeal joint, you will just see, the hand is going to be like this L, right? So it's your metacarpophalangeal joint, and these are the interphalangeal joint. Just make a snake, right? An L. It's a snake. Okay. So it's going to lead to, can I say that the lumbricals function is to make an L from your hand, right? And making L from your hand is only going to be possible if you are flexing at metacarpophalangeal joint and if you are doing extension at interphalangeal joint. Can I say that?
Yes.
Yes.
Is it clear? Okay. How do we make L from the hand? We are going to have flexion here at the metacarpophalangeal joint and extension here. Then I can have L, which is going to be the function of your lumbricals. So what is the function of the lumbricals? Lumbricals flexes the metacarpophalangeal joint, flexes your hand at metacarpophalangeal joint, and it would lead to extension of interphalangeal joint. Is this concept clear? Hello?
Yes.
So we have lateral lumbricals and we have medial lumbricals. The lateral two lumbricals are supplied by median nerve. Median nerve. And the medial two lumbricals are supplied by your ulnar. Okay, that's really important. We'll be discussing that in our hand module. But since we have these nerves here, so we should discuss a little bit about that. Okay. Okay, what is the nervous supply of ulnar nerve? Is going to supply this sensory on this 1.5 finger on the front and on the back 1.5 finger, right? Sensory. Both of these fingers, 1.5 on the front, 1.5 on the back. And on the back, the 3.5 sensory is going to be given by which nerve?
Radial.
Median.
Radial.
Radial nerve, right? So radial nerve
Yes.
at the back of your hand is going to supply that sensory innervation to 3.5. Okay, so in the front, on the palmar aspect, 3.5 sensory is going to be given by median. The other 1.5 is going to be given by ulnar. At the back, the same 1.5 is going to be given by ulnar, but the remaining 3.5 is going to be given by radial nerve. That's so simple, right? Okay, and ulnar nerve is also going to supply these, hypothenar muscles as well, right? Hypothenar muscles. We'll be discussing the thenar and hypothenar muscles in detail. What else it supply? The ulnar nerve supply all of your interossei muscles. What are interossei muscles? As the name indicates, intraosseous, between bones, right? So in between these bones, the metacarpal bones, these are your metacarpal bones. In between these metacarpal bones, you have a group of muscles which are called as interosseous muscles, right? Intraosseous. Between the bones, we have interosseous muscles. All of those interosseous muscles are going to be supplied by which nerve? Ulnar nerve. Am I right?
Yes.
Hello? And what are the function of these interosseous muscle? On the palmar aspect, interossei muscle are going to lead to adduction of your fingers. If you are adding your fingers to one another, right? And at the dorsal aspect of your hand, these interosseous muscles are going to be abducting your fingers. Is it clear? So on the palmar aspect, all the interossei muscles lead to adduction, and on the dorsal aspect, these interossei muscles lead to what?
Abduction.
Abduction.
Sir,
We are going to
sir, can you
discuss.
please repeat this concept? How
Okay.
on the on the
Okay.
palmar surface?
Okay, so we are going to discuss that in detail in our hand, right? In our hand module. But it was a small overview, right? We are going to discuss that in detail. Okay, so once I just show you the pictures from the side, then everything is going to be really easy for you. But as they were
Okay.
discussing the median nerve, so that's why I wanted to give you a brief overview of these nerves, right? Okay, so supracondylar fracture, we discussed which nerve is going to be gone? Median nerve, am I right? So if median nerve is going, are we going to have thenar atrophy?
Yes.
Yes.
Are we going to have sensory loss at the first 3.5 fingers?
Yes.
Yes.
Okay. So you should just keep that in mind, okay? Brachial plexus. As we discussed, brachial plexus are network of nerves which are going to supply the motor and the sensory innervation to your arm, right? So whenever we have damage of these nerves, we are going to be having different problems which we'll be discussing, right? So we know that they arise from C5 to T1. We discussed that. C5 to T1, we discussed we have different roots. From the roots, we are going to be having long thoracic nerve. We have trunks, we have division, we have cords. Okay, so the nerve lesion, let's discuss them, right? So we have axillary, radial, median, ulnar, and musculocutaneous, right? These are the nerves. From which trunks do they arise from? They arise from C5 to C6. You can just see it here. And we have long thoracic nerves, right? Okay, so let's discuss axillary nerve. You already know axillary nerve is going to supply which muscle? Deltoid muscle. What is the function of deltoid muscle? It's going to cause abduction above 15 degree till 90 degree. We know that. How do we have damage of axillary nerve? If we have anterior dislocation of your shoulder, we know that, or if we have direct trauma to the head of your humerus because both of them lie in close proximity to one another. Am I right? Hello? Hello?
Yes.
Yes, sir.
Yes.
Okay. Then we have our radial nerve. What is the function of radial nerve? We know that a radial nerve supply all of your extensor, right? Okay, it supplies your extensor muscle. So as the radial nerve is entering here, right, and the upper arm, what is the extensor of your elbow? Your upper arm, which extensor muscle do we have? What's the name of that?
Tricep.
Tricep.
Tricep is the extension of your elbow, right? That's an extensor, which is going to be supplied by your radial nerve, right? The radial nerve then enters into on the shaft of your humerus, we have a groove where the radial nerve basically runs, which is also known as radial groove. Keep that in mind. And as the radius come here, it's going to supply all of the extensor of our forearm. We know that, an extensor of your hand muscles as well. We know that, right? So all of the extensor are in the upper arm, tricep, in the lower arm, forearm, it's going to supply the extensor, and the hand is also going to supply the extensors as well, right? And it's also going to give the sensory to the back of hand, to all of the back of hand. Sensory, as we discussed, 3.5 given by radial nerve, right? We discussed that concept. Okay, so okay, just let's skip this slide. Okay, it's not of any significance. So whenever we have radial nerve lesion, right? For example, if we do not have radial nerve, so we can have two cases. Either we can have radial nerve injury here in the axilla. So if we have injury here in the axilla, so it means that the tricep function would be lost. Am I right? Tricep function would be lost. Extensor of the forearm function is going to be lost. Extensor of the hands function is going to be lost. Am I right? Hello?
Yes.
Yes, you're right.
If the extensor muscles do not have its nervous supply, it means the flexors are going to dominate. Am I right?
Yes.
Hello? If the extensors
Yeah.
do not have nerve supply, flexors are going to dominate. So won't the hand be like that? Flexions are going to dominate. Can I just call it as wrist drop?
Yeah.
Yes. So whenever
Yeah.
the radial nerve is injury, we are going to be having a wrist drop, right? So as we discussed, we can have two cases. Either we can have injury of the radial nerve here in the axilla, and as we have the axilla, injury of the radial nerve here, tricep is going to be gone, forearm, and the hand muscles extensor are going to be gone. Or either we can have here, the fracture of that humerus mid shaft fracture, and we discussed there lies a groove known as radial groove in which our radial nerve was passing, right? So if we have damage here in the radial groove, the tricep function would be spared, and all of the forearms and these lateral are going to be gone. Is it clear? So we can have two conditions. Either we can have damage of the radial nerve in the axilla, and as a result of that, the function of all of the extensor would be gone, including tricep, your forearm extensor, and your arm, your hand extensors. But if we have damage at the mid shaft, that is at the radial groove, we are going to be having sparing of tricep muscle. So tricep can still function. It can have the function, but the function of the forearm and the hand extensors are going to be gone, right? And again, we are going to be having a wrist drop. So let's discuss it in our further slides. We discussed that the radial nerve lesion. How can we have radial nerve lesion? We can have fracture of the mid shaft, because we know in the mid shaft we have radial groove where radial nerve basically passes, right? Sleeping with arm out over chair. If arm is out on a chair and you are sleeping, it can compress your radial nerve at the level of your axilla. So if at the level of axilla, the radial nerve is, injured, tricep is also going to be gone. Am I right? So that's why it's also known as Saturday night palsy. At Saturday night, people just used to drink a lot of alcohol and they, just sit on the chair and they just sleep with the outstretched hand, which can lead to damage of your radial nerve. Is it clear? Hello? Okay. So as we did, hello, are you guys following me? Hello?
Yes,
sir,
yes.
we are following you.
Okay, perfect. So we discussed the radial nerve is going to be here present in the groove, right? Here, right? So it's also known as spiral groove or radial groove, right? So vulnerable to compression against the bone. If we have compression of this nerve against the bone, again, we can have problem with this radial nerve, right? So radial nerve lesion, we discussed if at the level of axilla, your radial nerve is injured, what happened? Tricep weakness, weakness of the wrist and finger extensor. And sensory loss at the back of the hand, 3.5. We discussed that. Okay. Radial nerve lesion at the groove. Tricep function is going to be spared as we discussed, right? If you have damage at the groove, tricep won't be affected. But still the wrist is going to be affected. The sensory supply is going to be unaffected and the superficial branch of radial nerve is going to be damaged. So sensory loss on the dorsal surface is also going to be seen if you have damage at the shaft, okay, or the radial groove. The next nerve which we are going to discuss is musculocutaneous nerve. As the name indicates, musculo, it means it have to supply certain muscles and also have to give rise to supply of your skin as well, cutaneous skin. That is sensory supply. Am I right? So this nerve both have the muscular portion and it have the sensory portion. Really important. Okay, it's going to supply the bicep muscle. What's the function of biceps? Really, really important. Hello. What is the function of bicep muscle?
Flexion. Elbow flexor.
Flexion of elbow at elbow joint, right? What else?
Internal rotation.
What NBME MCQ? What else?
Supination.
Also flexion of the wrist, Kujro.
Supination. Perfect. So you need to flexion and supination of your forearm. That's really important. It's really important. You have an NBME MCQ on that, right? So these are okay. What else it supply? It supply the coracobrachialis muscle as well. Coracobrachialis. So we have a muscle which comes from the coracoid process of your scapula, and it's going to be attached on your brachium, that is hand, called as coracobrachialis, which is also going to be supplied by your musculocutaneous nerve, right? So musculocutaneous nerve basically supplies your bicep. It would supply the coracobrachialis. Bicep itself can lead to supination of your forearm as well. And the cutaneous is going to be the lateral cutaneous portion, right? The lateral portion of your arm is going to be the lateral cutaneous or sensory supply is going to be given by musculocutaneous nerve. So in the U-word, you are going to be having an MCQ. We have an individual, he have damage to a nerve due to which he cannot flex his arm. What do you think? Which sensory, in which part of his forearm the sensory supply is going to be gone? So what do you think?
Lateral form.
Perfect. Lateral form. Right? Okay. So this was all about your musculocutaneous nerve. Okay, let's discuss certain trunks. We have two trunks. Okay, three trunks: the upper trunk, the middle trunk, and the lower trunk. Right? Okay. Trunks: upper trunk, middle, and lower trunk. Okay. Okay. Remember, the upper trunk is going to give rise to which? Yes, it's going to give rise to which nerves? What do you guys think? Hello.
Mostly it's
Musculocutaneous.
the radials, the posterior
Radial.
roots.
Okay. What do you guys think? Which nerves the upper trunk is going to supply?
Musculocutaneous nerve.
Okay, musculocutaneous. What else?
Axillary also.
Axillary.
Yes.
What else?
Suprascapular.
Scapular nerve.
Yes.
Suprascapular. Perfect. Right. So the upper trunk is going to give rise to these nerves which we'll be discussing. Okay. So during birth, right? For example, if a baby is at birth, if you are just giving birth to him, the mother is giving birth to him. So sometimes what happens as we are just moving out the baby from the vaginal canal, so sometimes his shoulder can get stuck in symphysis pubis, right? Symphysis pubis. So if this is your symphysis pubis, you know your big, so the shoulder can sometimes stuck here. And as we are pulling the baby from the head, so you can have see the angle between the head and the shoulder would increase. If the shoulder is stuck and you're just pulling the head, it means this angle is going to increase. Am I right? Hello?
Yes.
Yes, it will increase.
The shoulder is stuck and I'm still pulling the head of baby. It means the angle here would increase. And this increased angle in the baby is going to lead to damage of the upper trunk. Really important, right? Upper trunk can only be damaged in this condition, right? Okay, so during the birth, you can see that the shoulder impedes the delivery. It's going to stuck in the symphysis pubis, and since if you are just moving out the head, it can lead to increase in the angle between your head and your shoulder, and as the angle increases, it can lead to tear of your upper trunk. If the upper trunk is gone, which nerves are going to be gone? The function of axillary nerve is going to be gone. We know that. The function of musculocutaneous nerve is going to be gone, and the suprascapular is going to be gone. So if the axillary nerve is gone, can the baby have abduction? Hello?
Abduction is not.
No.
No. So it means the hand
Not
would be
after
abducted. It means the opposite muscles are going to dominate and the hand in this baby is going to be adducted. Am I right?
Yes.
Axillary nerve also supplies your teres minor, we discussed. What was the function of teres minor? That was
Extended.
external
Adduction and
External
extension.
rotation.
Okay, it means we won't be having external rotation in this baby. So it means the arm would be internally rotated. Am I right? So
Yes.
adducted, internal rotated. Okay.
Then
And
abduction would be
muscular-
gone. Abduction would be gone.
So abduction would be gone. So the
Yeah.
hand is going to be adducted because the opposite group of muscle, the adductor, are going to dominate. Am I right? Hello.
Yes.
Yes,
we
you're
won't
right.
we won't be having abduction. So if no abduction, the opposite group of muscles that are adductors are going to dominate, right?
Yes.
Would lead to adduction of the hand. The musculocutaneous is gone. It means the baby cannot flex his hand. It means the extensor are going to dominate, right? So it means the hand would be extended, right? Hello?
Yes.
Okay.
Yes.
Yes.
And the suprascapular nerve is gone, so the infraspinatus, which due to external rotation, is also going to be gone, so internally rotated. So you can see adducted hand, stretch, okay, extended and adducted hand with internally rotated, right? Hello? So it's going to give a characteristic, hand. You can see the hand is adducted, internally rotated, and it's basically okay. So you can see it's adducted, internally rotated. What else? Extended, right?
And
It's extended.
pronated as well.
Okay. So you can see this is also known as a waiter tip sign, right? Some of the waiters, whenever they are just need tip, so they just do like their hands like that, right? Internally, so that's why it's also known as waiter tip sign. Okay. So whenever, okay, let's just revise it. Whenever we have damage to the upper trunk, which nerves are going to be gone? Axillary, musculocutaneous, and supra.
Scapular.
So if axillary is gone, no abduction, so hand is going to be adducted. You can see it's adducted, right? If no musculoskeleton, so no flexion, it means hand is going to be extended. You can see it's extended, right? And suprascapular nerve, which would lead to external rotation, so no external rotation, it means internally rotated. So you can see the hand is internally rotated. It's known as Erb's palsy or waiter tip signs. Really important, really important. And when do we have it? Whenever we are just, having a delivery of baby, and if his shoulder stuck in symphysis pubis, and still we are just, pulling out the baby from his head, it can increase the angle between head and his shoulder, which is going to lead to tear or injury of these nerves. Is it clear? So you can see this was your trunk, the upper trunk. You can see the upper trunk was basically giving rise to musculocutaneous. You can see it here. The upper trunk was also giving rise to your, okay, you can see the upper trunk giving rise to your axillary nerve, right? And what else? Upper trunk giving rise to your suprascapular nerve. Suprascapular, musculocutaneous, and axillary. Am I right? Hello?
Yes.
Yes.
Okay, perfect. So we discuss upper trunk. Let's discuss lower trunk. How can we have damage to a lower trunk? For example, if you have a child and he's falling out from a tree, he have climbed a tree and suddenly he just, as he's falling, he just holds a branch of a tree, right? So as he's hold the branch of a tree, it means now the angle between, okay, your hand and your abdomen, it's going to increase, right? The angle is going to increase. And suddenly if he just hold the arm, sorry, any branch of a tree, if he is falling, so in the UL MCQ, they're going to tell you the same condition. We have a baby, no, sorry, a child. He climbed a tree. He was falling from the tree, and suddenly he just, grab a branch of a tree. So what do you think? Which trunk is going to be damaged in this child? Lower trunk, right? Lower trunk is going to be ruptured or damaged. Am I right? So let's discuss which nerves do lower trunk give rise to, right? So this was basically your lower trunk. You can see, okay, just give me a second. Okay, just give me a second. Okay, so this is basically your lower trunk. Lower trunk give rise to your median nerve and it give rise to your ulnar nerve. Am I right? Hello?
Yes.
Yes, you're right.
Hello? Median
Yes.
and
Allah.
ulnar nerve. So now let's discuss if the median and ulnar nerve is gone in the inferior trunk injury or the lower trunk injury, what would happen? Let me just draw the diagram of your hand again, right? So we know that this is your hand, 1, 2, 3, 4, and thumb, right? This is your hand. We discuss, let's just discuss the function of lumbricals. We discussed these two lateral lumbricals are going to be supplied by which nerve?
Median.
Yeah, now.
Median nerve. These two, okay.
Allah
These
now. Allah.
are going to be supplied by ulnar. So it means that whenever the median nerve is gone and the ulnar is gone in the lower trunk injury, the function of the lumbricals is going to be gone, right? Am I right?
Yeah.
It was a function of lumbricals making L.
Metacarpophalangeal flexion and interphalangeal extension.
Yes. So how do we make L? We make L by flexion of metacarpophalangeal joint and extension of your
PIP and DIP.
interphalanges, right? So it means that no median nerve, no ulnar nerve, no function of lumbricals. You cannot make L. You cannot have flexion in metacarpophalangeal. That is, you are going to be having extension at metacarpophalangeal. You cannot have extension at interphalangeal. You will be having flexion at interphalangeal. So please make a claw and see whether it's a claw hand or not. In claw hand, we are extending the metacarpophalangeal joints and we are flexing the interphalangeal joints and making a claw. So can I say that in the lower trunk injury, the function of median and ulnar nerve is going to be gone. The function of lumbricals are going to be gone. So it's going to lead to claw hand. Can I say that?
Yes.
Yes,
Okay.
claw.
Perfect. So catching a tree while falling, okay, so you can see it's a claw hand. The function of lumbricals is gone. It means now you have extension here, okay, you have extension here and flexion at these joints, right? Here we are going to be having extension and here we are going to be having flexion. So you can see it's a claw hand, right? Am I right?
Yes.
Okay, so it's also known as clunky palsy or lower plexus injury. As we know that the lower trunk is going to give rise to two nerves, ulnar and medial nerve. So ulnar and medial nerve is going to be gone. It would affect the intrinsic hand muscles. We know when the median is gone, the muscles to the innervation to the thenar muscles is also going to be gone, and the hypothenar muscle innervation is also going to be gone. Am I right? Hello?
Yes,
Yes.
you're right.
Yes. Intrinsic muscle supply is also going to be gone. The flexors are going to be gone. We know that. So we are going to be having metacarpophalangeal joint hyperextended because the function of lumbricals are gone. And we are going to be having interphalangeal flexed again because the function of lumbricals are gone. It's going to be to claw. Is it clear?
Yes.
Hello? Perfect.
Yes.
So now let's discuss our last topic of today, that is thoracic outlet syndrome. What is thoracic outlet syndrome? Sometimes we can have an extra rib here, right? Right? Okay, so this is basically your thoracic outlet through which your brachial plexus are moving, just above the first rib, and some of the arteries and the veins of your upper arm basically are moving here, right? So it's a thoracic outlet. Sometimes we can have an extra rib. So if we have an extra small rib, so it would compress upon these structures. If I'm just compressing the veins and arteries, right? Let's suppose if an extra rib is compressing the veins, so we'll be having dilatation all over the hand. Am I right? Because you cannot have the venous return, the venous blood cannot enter into the heart. So it means we are going to be having backing up of the blood in the arm. Am I right? Hello?
Yes.
Yes.
And
Yes.
the rib is going to affect which trunk, upper trunk or lower trunk? What do you guys think?
Lower.
Lower.
Lower
Lower
trunk.
trunk. As the lower trunk is gone, can we have low hand?
Yes.
Okay, perfect. So, thoracic outlet syndrome. This is our thoracic outlet, you can see. And in this syndrome, we have an extra rib that is just behind the clavicles, which can compromise these blood vessels. Along with that, it can also compromise the different brachial plexus, right? Remember, thoracic outlet syndrome, we have muscles called as scalene muscles, right? So in between the anterior and the middle scalene muscle, you can see these nerves basically come out and these arteries come out. So you have a triangle there, right? Called as scalene triangle. In this triangle, we are going to be having moving out of these, these brachial plexus along with the blood vessels. This is really important. One of your U-word MCQ, they are going to ask me in thoracic outlet syndrome, the nerves and the vessels come out between which muscles? That are your scalene muscles. Is it clear? Hello?
Yes.
Hello?
Yes.
Okay, so as we discussed thoracic outlet syndrome, we have an extra rib, again extra seventh rib, and as we know, we are just doing hyper extension or flexion, above above our shoulder. So that extra rib can compress your lower trunk, and they can just compress. They can damage the lower trunk. They can compress the blood vessels as well, right? Leading to clumsy palsy, claw hand, as we discussed, right? And as we are having compression of the veins, it's going to lead to arm swelling, as we discussed. We can have arterial compression as well, which is going to lead to ischemia, right? And the pulses are going to be really weak if the arteries are compressed. We're going to be having, low systolic blood pressure there. We know that. Is it clear? Hello?
Yes,
Hello?
clear.
Yes.
Okay.
Yes.
Right. The last nerve which we are going to discuss is long thoracic nerve. If you guys remember from the roots of the brachial plexus, we were having that long thoracic nerve, right? Okay. Hello? Hello?
Yes.
Hello?
Yes.
Yes. Yes.
Yes.
Yes.
Okay, okay, good. Okay, so this long thoracic nerve is basically going to supply a muscle called as serratus anterior muscle. You can see it arises from the ribs and it's basically attached to the scapula. What is the function of serratus anterior? It's going to hold the scapula against your rib cage at your posterior aspect. It's going to hold your scapula tight against your rib cage as it is arising from your ribs attaching to the scapula. So this scapula is going to be held towards your body, towards your rib cage by this serratus anterior muscle. Okay, so if the long thoracic nerve is gone, serratus anterior muscle is gone. Now you do not have anyone to hold the scapula against your thoracic cage. So if you are telling this individual to please hold your hand on the wall and push it. So when he's just pushing his arm, the scapula is going to move away from the rib cage, which is known as winging of scapula. One of your UWorld MCQ. We have an individual, we tell him to just, stretch his arm, push the wall. And as he was pushing the wall, the scapula was moving behind the rib cage. We are having winging of scapula. What do you think? Which nerve is gone? Yes.
Long.
Long.
Long
Yes.
thoracic nerve.
Long thoracic nerve is gone. It's going to lead to winging of scapula, one of your UWorld MCQ. So whenever the patient presses an obsession against the wall, the scapula would protrude back. No, that's called as winging of your scapula. So that was all about today's lecture. The time is completed. Hope so you guys enjoyed and see you tomorrow.
Thank you.
Thank
Thank
you.
you.
Thank you. Bye bye.